Welcome. Welcome back to heart failure. This is the second session on heart failure. On the first session of heart failure, we discussed the pathophysiology of heart failure and the various compensatory mechanisms and the drug strategies. And we just introduced angiotensin converting enzyme inhibitors. I hope you know the mechanism of action of angiotensin converting enzyme inhibitors. We will just see how this mechanism is useful in heart failure. Have a look at the slide. Angiotensin converting enzyme inhibitors finally lead to decreased angiotensin, leading to vasodilation and decrease in the preload as well as afterload and fall in blood pressure. Then the next effect will be decreased sympathetic activity and decreased norepinephrine release. On the other side, they are going to block the aldosterone secretion, so the sodium and water retention will be less and there will be less cardiac remodeling, and they are going to conserve the potassium. Angiotensin converting enzyme inhibitors are indicated in all stages of hypertension, symptomatic to chronic. Even if the patient has mild dyspnea on exertion, no signs of volume overload, the patients who are asymptomatic, ejection fraction is less than 35%, is ventricular dysfunction or recent MI, and in general in all stages of left ventricular function failure with or without symptoms. So these are the conditions you can see on this slide for which the ACE inhibitors are used in heart failure. There are some green signals, good things about ACE inhibitors. It's good you learn this. On the constant use and the chronic use, ACE inhibitors have shown to decrease the morbidity and mortality and increase the survival rate in the patients with heart failure. That's very great. They prolong the survival, they decrease the morbidity and mortality, they decrease the incidence of myocardial infarctions. In general, they decrease the incidence of cardiovascular events. So when I'm saying cardiovascular events, it means myocardial infarction, it means stroke, it means cardiac arrhythmia leading to death. So they decrease the incidence of all this. They prevent the cardiac remodeling and they spare the potassium. They have the potassium sparing effect because they are acting against aldosterone. This potassium sparing effect is useful to decrease the incidence of arrhythmia. One very peculiar thing with ACE inhibitors is, do they stimulate the heart? No, they don't stimulate the heart. Do they suppress the heart? No, they don't suppress the heart. There's no effect on the heart. That's great about ACE inhibitors. Otherwise, if you try to use a drug which decreases the preload or afterload or which produces vasodilation, is immediately going to lead to the reflex tachycardia, palpitation, and there will be cardiotoxicity. This does not happen with ACE inhibitors. That's very peculiar, that's very different. So no cardiac stimulation, no myocardial suppression. So they are free of cardiac toxicity. That's very important. They do not worsen any associated diabetes mellitus or associated bronchial asthma. So they will be safe in patients with diabetes, safe in patients with asthma, and most importantly, they improve the nephropathy. They improve the nephropathy in patients who are diabetic as well as the non-diabetic patients. So with all these greens, there's no surprise that ACE inhibitors are the top candidates to be used for myocardial infarction. Let's revise the adverse effects of ACE inhibitors, which we did in the chapter of hypertension. Hyperkalemia, dry cough due to the accumulation of bradykinin, and angioedema and skin rashes, again due to accumulation of bradykinin. With captopril you get altered taste sensation, which is called dysgeusia, which may be due to the sulfhydryl structure, and with few ACE inhibitors you get the first dose effect. The first large dose can produce orthostatic hypertension. So that's the first dose effect. So these are some adverse effects of angiotensin converting enzyme inhibitors, and we know that they cannot be used in pregnancy because these drugs are fetotoxic. ACE inhibitors are captopril, enalapril, lisinopril, ramipril. We already did them in hypertension, but I'm saying it for your revision. All of them are prodrugs except captopril and lisinopril. This is an important matter for your questions. All the ACE inhibitors are in general prodrugs. Captopril is not a prodrug, it is active, and lisinopril is also not a prodrug, it's active, and they should be given on empty stomach for better absorption. Next we move to the next drug in heart failure, and that's angiotensin receptor blocking agents, the type of the receptor is AT1 receptor. So ARVs are AT1 receptor blockers and they block the angiotensin 2 receptor. This leads to decreased pre and after load because angiotensin will come down and there will be vasodilation in the venular as well as the arterial side, and the blood pressure will decrease. There will be decrease in the sympathetic activity and norepinephrine release, and aldosterone also will be blocked, and there will be prevention of cardiac remodeling. There will be decreased morbidity and mortality. I hope everything is looking like ACE inhibitors and you appreciate it. So what's the difference? Then when to use the ARBs? Especially if the patient is intolerant to angiotensin converting enzyme inhibitors. Could there be intolerance? Yes, it's possible. If the patient gets angioedema, if the patient gets skin rashes, and most importantly, a very common predominant adverse effect of ACE inhibitors is dry cough due to bradykinin accumulation. So if the patient cannot tolerate the drug because he has persistent dry cough, you'll have to think of changing the drug, and then your option is ARBs. So I am saying, especially when the patient is intolerant to the angiotensin converting enzyme inhibitor, because ARBs don't have an effect on bradykinin, so the dry cough is minimal. These drugs, examples, they are all sartans: losartan, candesartan, valsartan, irbesartan and telmisartan. And the adverse effects of ARBs is hyperkalemia, and the next one, it cannot be used in pregnant women due to the fetal toxicity. So it seems like the ACE inhibitors. We move on to the next important drug, and that's aldosterone antagonist. Is going to act as antagonist of aldosterone, block the actions of aldosterone. Aldosterone produces sodium retention and potassium loss. So these drugs are going to produce sodium loss and potassium retention. So potassium is going to be saved, potassium is going to be spared. So there is less sodium and water retention, sparing of potassium, and this prevention of hypokalemia is useful to prevent the cardiac arrhythmias. Aldosterone antagonists also decrease the morbidity and mortality, and they are the most important drugs to inhibit or prevent the cardiac remodeling, because we saw in the discussion of cardiac remodeling, aldosterone is an important culprit for the cardiac remodeling. The drug which is commonly used is spironolactone in the dose of 25 to 50 milligrams 2 times a day to 4 times a day. This is a very great support in the management of heart failure. Next, we move on to the next group. We discussed the ARBs, the ACE inhibitors and aldosterone antagonist. Now we go to the diuretics. What are the beneficial effects of the diuretics? Diuretics will produce diuresis, so the blood volume will be controlled, so there is decreased volume overload. They will relieve the pulmonary edema and peripheral edema and the orthopnea, the paroxysmal nocturnal dyspnea, etc., because they are excreting large amount of blood volume and the venous return is going to be less. So the heart has to pump less blood, the heart has to pump against less resistance because the amount of blood itself is now less. That's what I'm saying, less plasma volume, less venous return and decrease in the pre and after load. This is going to lead to improvement in the cardiac function. Diuretics are beneficial if we use them with ACE inhibitors or ARBs, or you better use them with potassium sparing diuretics, because most of the diuretics we are talking about are thiazide diuretics and they do produce hypokalemia. So it's good to use them with potassium sparing diuretics. Diuretics are two types. Loop diuretics could be used in emergency and thiazide diuretics could be used in the mild heart failure on long-term basis or on the chronic basis. Hypokalemia is important adverse effect of loop and thiazides, and potassium supplementation is required. But please remember, they do not produce any alteration in the pathology of heart failure. They do not produce any effect on mortality in the patients. Next, we move to direct vasodilators, and they also are to be chosen especially if the patient is not tolerating the angiotensin converting enzyme inhibitor drugs. An important direct vasodilator is your nitroglycerin or nitrate. I hope you remember the chapter of hypertension. I hope you remember the various vasodilator drugs and the chart I showed you. Nitrates and nitrites, they dilate the veins more than arteries. So they do decrease the preload, they do decrease the afterload. So both of them are decreased. Mainly preload is decreased because veins are dilated more than arteries. The names of the drugs: isosorbide dinitrate and nitroglycerin. An arteriolar vasodilator is hydrolazine, and because it's arteriolar vasodilator, it's going to decrease the afterload. And the drug which acts on both arterioles and venules, we just saw in hypertension, is sodium nitroprusside. Sodium nitroprusside is used by intravenous infusion for emergencies. One more important thing, there is a combination of nitrate plus hydrolazine. This has been shown to prevent the cardiac remodeling. So we got another group which can prevent the cardiac remodeling: ACE inhibitors, ARVs, aldosterone antagonist, and now nitrate plus hydrolazine. Next we go to a substance called brain natriuretic peptide, or BNP, or neziretide. This is now available as by recombinant DNA technique. What does this do? This leads to increase in the cyclic GMP, and this produces vasodilation. Vasodilation in the arterioles as well as vasodilation in the veins. In addition, it's got diuretic effect. So look at that. It's like having a diuretic having vasodilator effect. So that's why it's called natriuretic peptide. It's used by intravenous route and its half-life is very short, that's 18 minutes. And the adverse effects include fall in the blood pressure, obvious, because there's vasodilation, and it can produce renal damage. Neziretide is not used in each and every patient. It's reserved for refractory heart failure. This is why when we introduced heart failure and we tried to classify the drugs, one of the ways to classify was drugs which are commonly used and drugs which are used in certain situations. So if it's refractory heart failure, neziretide or brain natriuretic peptide. Next we move to the beta blockers, and I'm sure by this time you are well conversant with the effects of beta blockers. Let's see what is beneficial. Beta blockers will decrease the heart rate, will decrease the renin release, and will decrease the effects of catecholamines. They will decrease the sympathetic activity, and this is why the systole of the heart is going to be better. So there's improved systolic functioning. Now, next important thing, if you remember, we said catecholamines are responsible for cardiac remodeling. So beta blockers will be useful to prevent the apoptosis, the cardiac remodeling, the morbidity and mortality. So this is a beneficial effect of beta blockers in heart failure. But please mind well, they have to be used cautiously because beta blockers decrease the contractility. This has to be kept in mind. So they are not used routinely, they are used very cautiously in selected cases. And they are always used in low doses. Start with low doses and gradually increase the dose. When to use them? They are used in mild to moderate heart failure with dilated cardiomyopathy. Examples of beta blockers, I am giving you examples of only cardioselective beta blockers or beta-1 selective beta blockers. That's atenolol, metoprolol, bisoprolol, and carvedilol, which in addition has got alpha blocking property. Contraindication for beta blockers is decompensated heart failure. Already the heart is much worsened, there is decompensation, so beta blockers will worsen it. So we discussed various drugs, and now we have come to the positive ionotropic agents which are going to increase the contractility of the heart. This includes number 1, digoxin, includes IronDilators, that's bipyridine or milrinone, and beta stimulants in the form of dopamine and dobutamine. Lastly, there is alpha blockers and morphine. This also you could think of. Digoxin, when to use it? Digoxin is used especially in systolic dysfunction, and if the patient is not responding to your routine line of management, that's your AC inhibitors, ARVs, diuretics, they are not working, then you can go for digoxin, because digoxin is toxic. If the heart failure is associated with atrial fibrillation, digoxin is useful, and it is also useful for some other conditions like atrial flutter and fibrillation, where you can decrease the ventricular rate. You can control the ventricular rate. So for atrial arrhythmias like paroxysmal atrial tachycardia and AV nodal tachycardia, because digoxin decreases the AV conduction. There are the drugs like digoxin and digitoxin in this group, and the mechanism of action involves inhibition of the sodium-potassium ATPase pump. So when you inhibit this pump, there is increased sodium entry, increased intracellular sodium. This makes an advantage for the sodium-calcium exchanger, and there's increased intracellular sodium, also increased intracellular calcium. So it facilitates the calcium entry by affecting the sodium-calcium exchanger. So that's the mechanism of action. It decreases the ability of the sodium-calcium exchanger to move the sodium out. So to summarize, inhibits sodium-potassium ATPase, increased intracellular sodium, increased intracellular calcium. These drugs are obtained from plants. We call them cardiac glycosides, from Digitalis purpurea, that's red foxglove, Convallaria majalis, that's lily of the valley, and Helleborus niger, that's the Christmas rose. Digitalis actions in heart failure. I am putting it on this slide for you, and I request you to have a look at the slide and nicely understand how digoxin is acting. Have a look at it for 2 minutes and mark the salient features of this particular drug. Yes, number 1, digoxin increases the force of contraction, so cardiac output is increased. That was your problem, less cardiac output. Cardiac output is increased. Now the heart will be completely emptied. There will be better complete emptying of the heart. Next, increase in the renal perfusion, less activation of the renin-angiotensin-aldosterone system, and less sodium water retention. This is going to decrease the blood volume and decrease the edema. So all this is happening because of improved cardiac output. Have a look at the slide. Improved cardiac output. This is going to improve the perfusion to the kidneys, the blood flow to the kidneys. Once the blood flow to the kidneys is good, renin-angiotensin system is not going to get activated. So sodium water retention will come down, and the blood volume will decrease, and the edema will decrease. Next, not only kidneys, there's improved circulation to whole of the body, to all the tissues. So it improves the fatigue and weakness, and it brings down the sympathetic activity and retains the vehicle tone. So the heart rate is decreased. So once the heart rate is decreased, the demand of the oxygen decreases. It decreases the heart rate by another mechanism, that's it inhibits the AV conduction, decreases the AV conduction. So again, the oxygen consumption of the heart will be brought down. Go to the next slide. The systole is shortened by digitalis, that's abbreviation of the systole. So there is less fiber tension. This also decreases the oxygen consumption. And when the systole is shortened, the diastole is prolonged, and there is better filling of the heart. And I hope you know the blood flow to the heart itself happens during diastole. So there will be improved blood flow to the heart. This is how there is better energy utilization. In addition, it decreases AV conduction, so it can control the abnormal impulses coming to the ventricles from the atria. Have a look at the electrophysiological effects of digoxin, and I have put this on a slide for you to compare what happens when you give it in therapeutic dose, what happens when you give it on toxic dose, and the first column is showing you the individual tissue. So have a look at the slide. We start with SA node. Therapeutic dose, it decreases the rate. Toxic dose decreases the rate. Atria, it decreases the refractory period. In toxic dose also it decreases the refractory period, but this refractory period can be decreased too much. then it can lead to arrhythmia. Then the AV node, most important effect of digoxin. In therapeutic doses, it decreases the AV conduction, and in toxic doses, this can lead to AV block or atrioventricular block. Next, Purkinje fibers, ventricles. In therapeutic doses, it increases the PR interval and it decreases the QT interval. In toxic doses, all these effects can lead to extrasystoles, ventricular tachycardia, ventricular fibrillation, and arrest. So these are the electrophysiological effects of digoxin in therapeutic dose and in toxic dose. Next, we try to compare the two substances, two glycosides, digoxin and digitoxin. Absorption is 75% for digoxin. For digitoxin, it's more complete, almost 90 to 100%. Plasma protein binding is very less for digitalis, 20 to 40%. For digitoxin, there's very high plasma protein binding, 90 to 97%. Digoxin, the half-life is 36 to 40 hours. For digitoxin, it's a long half-life of 5 to 7 days. Therapeutic concentration for digoxin is 0.5 to 2.5 nanograms per ml, whereas for digitoxin, it's 10 to 35 nanograms per ml. As far as the levels are concerned, with digoxin, you need to maintain the blood level, its blood level, to less than 1 nanogram per ml. And for digitoxin, the toxic levels are supposed to be more than 35 nanograms per ml. As far as volume of distribution is concerned, for digoxin, the volume of distribution is 6 to 8 liters per kg, which comes to about 500 liters per 70 kg. And for digitoxin, it's 0.6 liters per kg, that comes to just 38 liters per 70 kg. In digoxin, we need to adjust the dose in conditions with renal failure, because renal failure precipitates digoxin toxicity. So we need to adjust the dose. And for digitoxin, dose adjustment is required in liver failure. So we go to the next slide to know the adverse effect. I have written on the top, digoxin adverse effects, low therapeutic index is not an adverse effect. I am just trying to remind you that there is low therapeutic index. So you can imagine it's a toxic drug. Let's discuss the adverse effects. Number one, cardiac. It can produce AV block or AV dissociation. We just now saw it. You treat it with atropine. How to treat this adverse effect is shown in front of the adverse effect in green color. Sinus bradycardia, treat with atropine. Supraventricular tachycardia and atrial arrhythmias, use beta blockers, adenosine or calcium channel blockers. For ventricular extrasystoles and ventricular tachycardia, use lidocaine, phenytoin or procainamide. So these are the cardiac adverse effects. CNS, yes, digoxin does cross blood-brain barrier, can produce headache and sense of fatigue and malaise, then confusion and neuralgia and blurring of vision, and very important is disturbance of color vision, what we call xanthopsia or chromatopsia, and it can also lead to the hearing defects. Digoxin produces predominant profound nausea. It can produce nausea, sense of anorexia, vomiting and diarrhea. Lot of patients get this digoxin toxicity, and this could be the first symptom of digitalis toxicity, that nausea. And rarely it can produce gynecomastia and skin rashes. Precautions and toxicity is monitor the digoxin level, monitor potassium level, that's very important, and give potassium supplements. You can also use potassium sparing diuretics with digoxin to take care of this hypokalemia and monitor the ECG. If there is digoxin toxicity, we have a specific dose drug available to treat it. And it's a fractionated antibody. It is called Digipine. It's digoxin specific immune antibody fragment. Its most specific therapy for digoxin toxicity to be given by intravenous route of administration. 40 milligrams of Digipine will work for about 0.5 milligrams of digoxin. Digitalis toxicity gets precipitated by hypokalemia and hypomagnesemia, that's less potassium and magnesium, and more calcium. Next, Just now we said if there's renal failure, if there's hepatic insufficiency, the toxicity gets precipitated, and the toxicity is more at old age in patients with myocardial infarction or ventricular tachycardia or myocarditis, and patients who have thyrotoxicosis or myxedema. It also gets precipitated in certain other situations like hypokalemia, which is produced by thiazide diuretics, loop diuretics and steroids. The next group of drugs is quinidine, verapamil and amiodarone. Please remember, these drugs decrease the renal clearance of digoxin and is going to accumulate. And lastly, erythromycin is going to inhibit its metabolism, so digoxin is going to accumulate. Please remember, Digitalis decreases AV conduction and it increases the effective refractory period of AV node, so it's useful in case of atrial fibrillation to decrease the amount of impulses going from the atrium to the ventricles. Digitalis versus other agents, yes, Digitalis improves the functional status. Digitalis is a very potent cardiac glycoside and an ionotropic agent which makes the heart to utilize its energy better, but prolongation of life is better with other agents, and Digitalis also has fairly long half-life which can lead to accumulation, and most importantly it's a toxic agent and it has got low margin of safety. Next we move to the Ionodilators or bipyridines. These are called phosphodiesterase 3 inhibitors. They are non-glycoside and they are non-sympathetic Ionodilators. So two effects, ionotropic plus vasodilator. So we call it Ionodilator. They increase the cyclic AMP and they increase the calcium influx. So there is increased contractility, but they also produce vasodilation. So there is decrease in the preload and afterload. And we use these drugs for acute, severe or refractory heart failure, and if there is exacerbation in chronic heart failure. Ionodilators is inamrinone or amrinone. This is toxic, which produces bone marrow suppression, thrombocytopenia, hepatotoxicity and cardiac arrhythmia. So what is preferred is milrinone, and it has less incidence of thrombocytopenia. It's 10 times more potent than amrinone and it's highly selective for PDE3 and is a short-acting agent. In this group we have a new agent that's called vesnarinone. We move to the next group, and that's beta agonist. These are also ionotropic agents, and dopamine is used when there's severe hypotension or there's cardiogenic shock. Dopamine in the dose of 1 to 2 micrograms per kilogram body weight per minute. I'm saying a very short dose for dopamine. It acts on the D1 receptors and leads to renal vasodilation. That's a very beneficial effect. It takes care of the renal blood flow. In a little larger dose, that's 2 to 10 micrograms per kilogram body weight per minute by intravenous infusion, it produces this beta 1 agonistic effect and it stimulates the heart. So please remember, this dopamine will be useful if you are using it in a low dose. You don't have to go about 10 micrograms per kilogram body weight and then later it's going to lead to vasoconstriction. So you can know the range is 1 to 2 microgram per kilogram per minute, useful for vasodilation. So you give between 2 and 3 and 4 microgram per kilogram per minute, you would get both the beneficial effects, renal vasodilation and stimulation of the heart. Dobutamine. Dobutamine is an atypical substance. It's a selective beta 1 agonist, increases the contractility, increases the cardiac output and decreases the ventricular filling pressure. What's most important is it does not increase the heart rate, and that's great. So dobutamine is sometimes used in refractory heart failure or acute heart failure in the hospital setting. The other drugs used in heart failure are alpha blockers and morphine. That's heart failure. Thank you.